Now let's discuss about the pathogenesis of dengue infection. It starts when an infected female Aedes mosquito bites a person for a blood meal. During mosquito feeding, the virus is inoculated into the blood. Female Aedes mosquito requires blood for their egg maturation. Unlike other mosquitoes, they are daytime feeders. They usually bite on the back of the neck and ankle area. Primary reservoir of the virus is human. When an infected person is bitten by a non-infected Aedes mosquito, the virus is transmitted into the mosquito and it becomes infected. When this mosquito bites on another non-infected person, the person also becomes infected. This is the main method of viral transmission. Patients who are hospitalized for suspected dengue infection are advised to stay within bed nets to avoid transmission during an outbreak. Because an individual with dengue infection can transmit the disease for about 4 to 5 days. Cell and tissue trophism of the virus plays a major role in pathogenesis of dengue infection. 3 major organ systems are affected by the virus: the immune system, liver, and the endothelial lining of blood vessels. During a mosquito bite, virus enters through the skin and infects immature dendritic cells, which are located in the skin. Then these infected dendritic cells will reach the lymph nodes. At the lymph nodes, monocytes and macrophages recruit to halt the infection. However, these cells also get infected by the virus. When these cells become infected, they secrete large amounts of cytokines into the bloodstream, which mediate the early, non-specific symptoms of the infection. Not only that, when the monocytes and macrophages get infected, they are unable to halt viral replication, and this will result in increased viral load, while the host monocytes and macrophages undergo death by apoptosis. Increased viral load will result in dissemination of the virus via bloodstream and reach the vital organs including bone marrow and the liver. Direct destructive action of the virus on bone marrow precursor cells will cause thrombocytopenia and leukopenia. And due to the cellular destruction, patient gets a severe bone pain. And because of its severity, this pain is also called break bone pain. Hepatocyte damage will give rise to elevated transaminases in blood. And due to endothelial cell damage and thrombocytopenia, patient will have minor hemorrhagic manifestations we discussed above. As we discussed before, secondary infection with another serotype will give rise to a more severe clinical presentation than the primary infection. Immunopathology behind this condition is not well understood. Currently accepted theory is as follows. Almost all the patients with severe dengue have a previous history of dengue infection with one or more serotypes. During a secondary infection, T cells produce small amounts of non-neutralizing antibodies, which are directed to the surface proteins of dengue virus. When these antibodies bind to the surface proteins, macrophages and monocytes get attached to the Fc portion of the antibodies in order to neutralize the virus and halt the infection. However, as the serotype is different from the previous infection, macrophages and monocytes are unable to halt the infection. Instead, they form antigen-antibody complexes, and the virus continues to proliferate unchecked. This will result in the production of large amounts of cytokines and complement system activation, which are the main causes of extensive vascular effects in severe dengue. And this whole process is called antibody-dependent enhancement. Also, the non-structural protein 1 or NS1 antigen of the virus can directly activate the complement system, which also contributes to the vascular effects. Early